Okay, so today we are going to talk about something every ICU doctor and RT has faced or usually faces: ventilator management. We know that textbook protocols give us a very structured approach, but when you are at bedside, things don't always go as planned, right? So today we'll break down where the gaps are and how do we actually manage ventilator cases in real life. So ventilator management is a critical part of ICU care, and textbooks provide us very structured approach, structured guidelines, but real life patients management will often require a bedside modification. The challenge will lie in balancing evidence based recommendations with an unpredictable nature of a critically ill patient. Now, ventilator protocols are designed to provide structured approaches based on an underlying pathology. For example, we can say ARDS patients, we give them a low tidal volume, we give them high PEEP, they should have a permissive hypercapnia. COPD patients, on the other hand, should have a low RR, prolonged expiratory time, and we should avoid a dynamic hyperinflation. CO2 accumulation should be avoided. Neuromuscular disorders, full ventilatory support, and we prevent diaphragmatic fatigue in these patients, right? Post-operative patients, early weaning, spontaneous breathing trials should be given before extubating them. In theory, these protocols protect the lung, optimize oxygenation, and they provide a ventilatory induced lung injury, prevent the ventilatory induced lung injury. But what happens in the hospital is completely different. In real world ICU settings, ventilator management is rarely a straightforward case. Patients don't always fit the textbook criteria, and strict adherence to protocols can sometimes do more harm than doing good to the patients. So, what actually happens in hospital when things don't go as planned? Let's start with a acute respiratory distress syndrome patient who cannot tolerate a low tidal volume. Okay, so textbook says use 6 milliliters per kilogram PBW tidal volume. But in reality, some ARDS patients will fight the ventilator, they will have dyssynchrony, they will have increased work of breathing, and it can sometimes cause a self-inflicted lung injury. What do we do in ICU about these patients? Instead of rigidly sticking to 6 milliliter per kilogram, we sometimes allow a slightly higher tidal volume, like 7 to 8 milliliter per kilogram. Now, if it improves the comfort of the patient and it causes synchrony without excessive plateau pressures, great. And we adjust the flow rates and we sedate them and we give them paralytics if the patient is not tolerating the ventilator at all. In severe cases, we can put the patient on a prone position, or we use ECMO if needed. Now, COPD patients. COPD patients developing an auto PEEP. Now, textbook says use low respiratory rate and increase expiratory time. In reality, despite the correct settings, CO2 may continue to raise and air trapping can still occur. So what do we do in these cases? We reduce the tidal volume further to minimize air trapping. Now we also consider increasing an external PEEP like 5 to 7 centimeter H2O, so that we counter the auto PEEP that is the real problem and help with the triggering. So if CO2 remains high but pH is acceptable in these cases, permissive hypercapnia is allowed. Yes, we sometimes allow permissive hypercapnia if pH is acceptable and CO2 is still high. Now, weaning protocols that sometimes don't work. Textbook says us that patient passes a spontaneous breathing trial, extubate him. Reality, many patient passes the SBT, but they fail to extubate due to weak respiratory muscle, sometimes airway edema, sometimes secretion burden, and many other reasons. So what do we do in ICU for these type of patients who fail to wean despite having a spontaneous breathing trial positive? We conduct a daily weaning assessments rather than a one-time trial. We use a cuff leak test to check for an airway edema. And then if extubation is uncertain, we give them a high flow nasal cannula or an NIV and post extubation to prevent re-intubation. Now, textbook says us that PEEP improves oxygenation in patients with ARDS. High PEEP in ARDS causes hypotension. Right? In reality, high PEEP may impair venous return and cardiac output that lead to a hypotension in a patient with ARDS. So in that cases, what we do is that we lower the PEEP while we maintain the oxygenation of the patient. We give them fluid boluses, we give them vasopressors if needed, so that we support the perfusion of these patients. And we sometimes put the patient on a prone position so that we improve oxygenation without excessively increasing the PEEP. Now, the real solution here is a hybrid approach. In hospitals, we don't blindly follow protocols. We adjust on patient's response. The key to ventilator management is to understand the physiology, monitoring the trends, and making real-time adjustments. So, how do we bridge the gap between the theory and the reality? We use protocols as a starting point. Okay, they provide structured, but adjustments are always needed. We monitor ABGs. Third, we optimize synchrony before restoring to sedation. Minor tweaks in flow, trigger sensitivity, or race time can improve the patient comfort. And remember that weaning is not one size fits all. Extubation readiness is more than passing an SBT. And team approach matters in the end. In real life, RTs, nurses, intensivists, they all work together to fine tune ventilation strategies. So, to wrap up, ventilator management isn't about protocol versus bedside. It's all about balancing both. The best ICU doctors know when to follow protocols and when to deviate based on the patient's real time needs. And remember, medicine is learned in books but mastered at bedside. Thank you.